When I started college, I wanted to work for Doctors Without Borders and provide life-saving medications. But then I quickly realized that despite all this training, it was actually inadequate to some of the tasks at hand. And that really got me thinking about these large-scale social forces that determine the distribution of disease. My name is Marcella Alshon, and I'm a physician economist. Health disparities in the United States are profound. I think physicians and economists are still struggling to understand the role that structural racism has played in the distribution of resources and the outcomes of illness or health. I first heard about the Tuskegee study when I was an undergraduate. It just seemed incredulous to me that up to 1972, this experiment had been ongoing where Black men in the South, many of whom didn't have the opportunity for education, were being denied treatment for syphilis, which is treatable with penicillin. They were not told that they were in an experiment. In fact, they were actively deceived and told that they were receiving treatment for quote-unquote bad blood. Along with Marianne Wanamaker from the University of Tennessee, Knoxville, we were able to really probe this hypothesis that Tuskegee had been a watershed event that didn't just have terrible implications for the 600 or so men that were involved in the study in Macon County, Alabama, but the spillover effects that might have had on a whole generation of Black men. And our results were haunting. They showed that, in fact, there was a drop in healthcare utilization for Black men, an increase in mistrust, and our estimates suggest that life expectancy for Black men at age 45 was reduced by about 1.5 years. And this explained about a third of the Black-white life expectancy gap at the time. We wanted to take the next step and use rigorous economic methods to evaluate a policy that is often prescribed to reduce health inequality, which was to diversify the workforce. As a clinician, you know that it's always easier to prevent a disease than to try and actually treat it. And yet, there are gaps in the take-up of preventative care across racial groups. And so we wanted to examine whether providing Black men with a racially concordant healthcare provider could actually increase their demand for preventative health care. We ended up actually having to create our own pop-up clinic, more or less, and we hired 14 physicians to provide preventative healthcare services to Black men. Once in our clinic, we randomly assigned the men to either having a Black male physician or a non-Black male physician. And there were actually 2 stages to our experimental design. One is that we showed the participants a picture of the doctor that they were randomized to, and then asked what services, if any, they wanted to receive. And then in the second stage, they actually got to meet their assigned doctor, talk to them about the services, and then basically re-optimize what services they wanted to receive yet again. The reason why we had these 2 stages is because if there was just some sort of aversion for a particular type of physician, then we would have picked that up after the first stage. Our study showed when the Black male patients were actually able to speak to the Black male doctor and ask them questions and get answers, we saw really massive increases in take-up after those clinical encounters. So increases in 50 to 75% for quote-unquote invasive services. Particularly in preventative care, trust is so important. I hope that my work provides rigorous evidence, not only what leads to health inequality, but what are the ways that we can address it.